So when I got this topic, it's sort of a second nature topic on some levels, but when I looked at the really cool meeting agenda, it dawned on me that what this talk really should do is just set the table, and really for sessions that are going to come over the next several days. So the specifics are going to come in talks to come. I don't have any disclosures, as many of us in ACHD have found. They're hard to come by. If anybody would like to offer any, I'd be happy to consider. So let's do a little definition just so we make sure we're all on the same page. We did a heart failure and congenital heart disease scientific statement, and it turned out to be a little trickier than one might think to actually just establish a definition of heart failure and congenital heart disease. But I'll draw your attention to it being a syndrome characterized by either pulmonary or systemic venous congestion, or both, and or inadequate peripheral oxygen delivery at rest or during stress, caused by cardiac dysfunction. So it's a relatively broad statement. That's something that the European Society has used to define heart failure, and we use that in the scientific statement that a really talented group of folks contributed their minds and education to. So what's different and what's the same? Well, let's start with what we see in clinic. This is actually just patients that I've seen in the last several weeks. 23-year-old man with hypoplastic left heart syndrome, with some AV valve regurgitation that you can see there. Other patient is somebody I met Tuesday, who's a 21-year-old who's got congenitally corrected transposition, who's had a variant of a double switch operation that includes a Glenn shunt in addition to redirection of his IVC flow. Pulmonary atresia with an intact ventricular septum in a 38-year-old who has heart failure, and I saw her because we put an RVAD in her several years ago because she wasn't a transplant candidate. And over here, 46-year-old with more generic-looking heart failure. That is a left ventricle, and it doesn't squeeze well. Tetralogy of Fallot has an ejection fraction that falls into a category that's more easily characterized in adult heart failure sorts of ways of thinking. So what's different? Like, that's really obvious. None of those things are the same thing as acquired heart disease, much like this sign. I have no idea why it's required that we say that that's a stop sign twice, but it's a stop sign twice. So sometimes things are really obvious to us. It is obvious that these patients are different. But how do we actually put that into a more manageable circumstance that we can actually work with through clinic? So what are the causes of heart failure and congenital heart disease? Which ones are similar to those in acquired heart failure and which ones aren't? So in the scientific statement, we sussed out all of the available causes of heart failure as defined in congenital heart disease and came up with a list. And the list is it's deliberately broad and to some degree encompasses a lot of that variety that was just represented by those 4 patients. So volume overload from left to right shunts and valvular regurgitation, pressure overload from valvular disease or obstructive lesions, or we might throw in there hypertension, ventricular failure from intrinsic myocardial dysfunction, pulmonary hypertension, systemic arterial hypertension, other things that are more typical of acquired cardiovascular disease. As we get older and older patients, we start seeing the superimposition of coronary artery disease. One of my 83-year-old tetralogy of Fallot patients passed away recently. We try to avoid the frequently thing, of a LAD infarct. She had a myocardial infarction and had LV failure that developed as a consequence of that. So she survived 83 years with tetralogy of Fallot to succumb to coronary artery disease. Cyanosis and intractable atrial arrhythmias are all potential causes of heart failure and congenital heart disease. So which of these, though, are really unique to congenital heart disease, and which of them overlap with acquired cardiovascular disease? And I'm going to get to why I think it's important that we remember both of these things. So the things that are really unique to congenital heart disease, the volume overload related to shunts. And for those of you who are adult cardiologists in the room who did adult cardiology training and didn't really do any PEDS training, remembering the importance of shunts is something that doesn't come second nature until you really dive into congenital heart disease. I think pulmonary hypertension, and Sasha's going to talk about that along with others, pulmonary hypertension in the face of congenital heart disease is a different actor than is pulmonary hypertension in the setting of acquired cardiovascular disease. And then cyanosis is obviously something that's a very different animal that we see in adult congenital heart disease that is not really encountered in acquired cardiovascular disease. But when you look at acquired cardiovascular disease and think about just the heart failure patients that one might see in a typical adult cardiology clinic, Volume overload from valvular regurgitation is not uncommon. Pressure overload, severe aortic stenosis, we have a rampant TAVR program on the basis of pressure overload causes heart failure. And it's not specific just to adult congenital heart disease. Ventricular failure from intrinsic myocardial dysfunction. That's a huge thing in acquired cardiovascular disease. Pulmonary hypertension can occur, but it's not quite the same as with congenital heart disease. Coronary disease is obviously kind of the epitome of acquired cardiovascular disease. And the atrial arrhythmias, I've left that as seen with both, but I think we all recognize that congenital heart disease patients will do much more poorly with atrial arrhythmias on the whole than will those with acquired cardiovascular disease. So if we look at all of those causes, when we're seeing our adult congenital heart disease patients, who do we really need to think about differently, and what are our takeaways? So if there's so much that's actually overlapped, what really does make us different that we need to focus our clinical and research attentions on? So at first I started out with 5, but then I came up with 8. I'm a Seattle Seahawks fan, so I should have come up with 12, but there wasn't enough time for that. So one thing to take away, and that is always the key thing that we bring to the table in so many circumstances where our patients are shared with adult cardiology, that some causes of heart failure in adult congenital heart disease patients are reversible. So here is a patient with tetralogy of Fallot, a big transannular patch, and pulmonary valve dysfunction, both stenosis and regurgitation. That valve gets fixed, the symptoms of heart failure may well improve. Over here is a patient with a mustard repair who's got obstruction of the systemic venous return from the SVC. That particular patient could symptomatically improve with alleviation of that obstruction to venous return. Over here is a patient who had a coarctation, who had recurrence of coarctation, hypertension, and some heart failure symptoms on that basis, whose hypertension became much more manageable once residual coarctation was stented. Notice that's sort of a funky place for a stent, but that's the emphasis. Even within coarctation or some disorder that seems a bit simple, you may find some surprises about how you're going to have to treat them. Right ventricles aren't left ventricles. This is from Carol Warrens' paper on right ventricles, and just a couple of clear distinctions of what we know to be the case. The right ventricle stands up to way more than we would have given it credit for, put into unusual circumstances, such as systemic pressures, whether they be subpulmonic or systemic, but it is fundamentally built differently, and therefore it is not necessarily going to respond to our treatments in exactly the same way. The right coronary supplies the right ventricle, and it's accustomed to, in most circumstances, and built for a low-resistance circuit. So I feel like every time I'm in clinic, the right ventricle is just the iterations of what makes ACHD so hard. Systemic right ventricles, hypoplastic left ventricles so that the RV is really the dominant and single ventricle, and then navigating a subpulmonary right ventricle in patients with tetralogy of Fallot. The idea of just medically treat their heart failure, which is what many of our fellows will first come through of learning congenital heart disease, oh, well, we'll just medically treat that. I think we all know that that's not as easy as it sounds. The pressure load impact on the left ventricle, I think we all kind of have a good grasp of aortic stenosis and its effects. But there is good data, this is a study from Boston Children's amongst others, of fibrosis in left ventricles in children and young adults with aortic stenosis. And we have this building data that pressure-loaded ventricles, even if there's no systolic dysfunction, that had the pressure load either during development or over decades, are a different animal than the heart failure preserved ejection fraction than we see. Different insofar as perhaps being more severe, and probably different in that we might be able to intervene earlier and have a beneficial impact, but that it may also not respond to the limited therapies we have to offer. And then there's the single ventricles. Those are just, as we all know, harder. Andrea really encompassed a lot of those things. Single ventricle down here, if you can't read it, okay, Williams will vote. How many here say the heart has 4 chambers? So in Fontan patients and single ventricles, obviously that alone is a fundamental issue that's different. And Fontan palliation, as we're going to touch on extensively through this conference, is a multi-system disorder. So that is quite different than acquired cardiovascular disease. And extrapolating therapies for coronary artery disease, specifically to single ventricle patients, becomes a tremendous challenge. The hemodynamics that we see may not be typical of heart failure. This is the echo I showed you earlier of the patient with hypoplastic left heart syndrome who was transplanted recently. That's his cath, and I direct your attention to his wedge pressure, which is 4. He has heart failure despite low filling pressures. So in the case of our congenital heart disease patients, that classic paradigm of venous and pulmonary congestion as cause and therefore treatment strategy for heart failure may not necessarily apply. We have a lot of tricky physiology, and it's not specific just to Fontan repairs. Also here is the addition of pulmonary hypertension. This is one of our mustard repair patients who, if you notice here, has mean pulmonary artery pressures of 53 that were found when he was being evaluated for transplant. With therapy, his mean pulmonary artery pressures come down to 19 and his PVR drops. Pulmonary hypertension was a really important part of his physiology. It can be treated, but it could also be limiting. This was done as part of his transplant evaluation. If we could not lower his pulmonary vascular resistance, transplant was not going to be an option for him. And pulmonary hypertension in his setting is a different animal than some of the pulmonary hypertension we see either as PPH or in the setting of acquired cardiovascular disease. But we have some data on treating pulmonary hypertension. This is just the original BREATHE-5 trial, just to emphasize that we do have some randomized clinical trials that will demonstrate the beneficial effect of treating some of these disorders in ways that are actually better than what we have for treating those disorders in acquired cardiovascular disease. The mechanisms of fibrosis, and Craig and others in the room have done work on this. The fibrosis itself, there's a tremendous overlap probably with what a fibrotic ventricle looks like between acquired cardiovascular disease and congenital heart disease. But the mechanisms by which the fibrosis develops and the period of time over which it develops are probably quite different in congenital heart disease than they are in acquired cardiovascular disease. We certainly don't have the robust understanding of it, and therefore knowing which therapies are going to have a directed effect is still a work in progress and a really important one. And then we don't have as much data. So let's kind of remind ourselves of a couple of things about acquired cardiovascular disease. We can be a bit envious as well. LV systolic dysfunction, large trials, thousands of patients. Us, some of our biggest trials have 88 patients. One of our biggest trials has 88 patients. Large numbers of significant events over short periods of time. Thankfully for us, we get to follow our patients over decades and decades. But it means that there are relatively few events that occur over decades, and therefore we really kind of have to work to figure out how we're going to study these patients to demonstrate that we're having a beneficial impact. There's relatively little heterogeneity. My heart failure cardiologist will initially look and say, oh yeah, we've got a lot of heterogeneity in our clinic population. They have some amyloid disease, they have chemotherapy induced, they have MIs, they have dilated cardiomyopathies. But it's nothing compared to the extraordinarily heterogeneous group of patients that we take care of with not just different anatomy, but different surgical procedures, and then different effects of both of those things through generations of their life. Lots of prognostic markers that have been really well vetted in acquired cardiovascular disease. Andrea tells us it's okay for us to say, I don't know. Thank heavens, because I say that a lot in clinic, because we're still working to figure out how to tell people what to expect over time. We lack some of the prognostic markers that are available in acquired cardiovascular disease. So, never thought I'd miss this guy, but there you are. Known knowns, there are known unknowns, and there's also unknown unknowns. Times they do evolve, and we are in a place of all of those things. So what do we know a little bit? We could envy the acquired cardiovascular disease literature, or we should take advantage of it. So what about that data? Let's remind ourselves of just two things real quickly. The SOLVE trial, several thousand patients, and this is from the 1990s. New York Heart Association class 2 to 3. Average follow-up was 41 months, and I draw your attention to the horrifying event rate of deaths. It was 40% in 41 months. So when we look at trying to create trials or study the effect of acquired cardiovascular disease medicine, we are fortunate that we don't have those event rates, but it does make it much more challenging to study the effect of therapy. Same thing with MERIT-HF, which is one of the beta blocker trials for heart failure. Even in the background of ACE inhibitors at that point, there were still a substantial number of actual deaths. So we are going to have to be creative in how it is we go about both treating and studying our patients when we don't have those sorts of event rates to really kind of hone in on preventing or alleviating in terms of, for example, heart failure exacerbations. And as sort of, I guess, a commentary on the times as they are, we are different than acquired cardiovascular disease, but if we spend all of our time figuring out our differences, we're never going to take advantage of all of our commonalities. So When you hear hoof prints, here's the horse that is cardiovascular disease. That's certainly how I see us every day, is the sassy little zebra with many different colors. But we probably are this thing actually I think is called a horbra, but I don't really know. It's part horse, part zebra. So somewhere in there, we will evolve to be a field that takes some of the best from acquired cardiovascular disease, but also plays our own differences to really understand and overlap, and probably actually inform back to acquired cardiovascular disease how best to both study and then treat those patients with heart failure and congenital heart disease. When you take that simplistic look at the effect of heart failure medications in acquired cardiovascular disease, can we make an argument that some of our patients really do fit that mold? And I think this is going to get touched on later. Actually, I know it's going to get touched on later, but we do have some evidence that neurohormonal activation, which is an important feature of acquired cardiovascular disease medical therapy, is a feature of ACHD patients. There's BNP as a neurohormonal modulator or marker. So in those patients, there probably is some value in at least thinking through using acquired cardiovascular disease therapies because they have so much robust data behind them. There are going to be a number of patients, and we all see them in clinic, who will respond in a similar fashion to those with acquired cardiovascular disease to standard heart failure therapies. But we really need to hone in on a lot of these other reasons first. Make sure that you've gone through, just to state the obvious, and address the reversible causes and really understand their physiology. So how do we actually treat these patients? This is a moral of two things. One, be real careful what you email folks. I queried a number of years ago, and some of you have seen this, how do you manage your heart failure patients? One esteemed ACHD cardiologist, frankly, I mess around until they feel better, and their BNP decreases without destroying their kidneys. I then congratulate myself on my foresight and clinical acumen until they get overloaded again, at which point I blame the nephrologist. Yes, that is the right answer. Always blame the nephrologists. So that is one option, and the other is that you have to individualize therapy. So understand your patient's anatomy, physiology, hemodynamics, and where they might fit into that spectrum of response to therapy versus not. And I think that I will just conclude, hopefully, to set the table for the sessions to come by saying that heart failure and congenital heart disease comes in many forms. But I think the things that we really are honed in on, that we sort of second nature know that are really quite different, are right ventricles in all their forms, systemic, subpulmonic, and syncal, Fontan palliations, and pressure-loaded LVs that have been pressure-loaded over decades or during development, all may be very different in their response to standard heart failure therapies. We obviously need more data, but we're going to have to be way more creative about how we do it. Registries are going to end up being important, and just more novel techniques in figuring out response. Individual extrapolation, you really have to understand, but then be willing to bail out on it if it's not working the way you expect it to. And a lot of times we'll hear simple things like, oh yeah, ACE inhibitors, they've been proven not to work in adult congenital heart disease. I would encourage people to be cautious in that assumption. We may not have studied the right patients yet. I would assert we haven't. And therefore, we can't say for sure that they don't work, but we certainly can't offer the same assertions that they do work that we would to somebody with acquired cardiovascular disease. So although we don't have data, it does just put us in that position, which is intellectually really exciting, but is also sometimes frustrating, where we have to use everything at our availability to figure out the best way to treat our patients and really individualize their treatment plan. And with that, I'll end and hand over to the rest of the crew. Teamwork makes the dream work.
Thanks, Karen. Obviously addressing many of the issues that we have to address with every single patient that we look after. Karen, are you a therapeutic nihilist or are you a optimist? You said, let's take ACE inhibitors. I think it's fair to say, while they haven't been proven not to work, they haven't been proven to work.
Correct.
So if you're a nihilist, you wouldn't use them until you've got evidence that they work. If you're an optimist, you would.
I am 100% an optimist. I do use them. I don't use them as prophylactic therapy for something because I don't think that we have a robust amount of data on that. I don't know if anybody else does the same thing. If they came to me from a pediatric clinic on it, I tend not to stop it. Then I have to explain to all my patients, or all the fellows, why the patient's still on digoxin for no seemingly good reason. But I will continue therapies once started, but in totally asymptomatic patients with no evidence of neurohormonal activation. I'm not just going to start an ACE inhibitor to start it, but man, I'll jump on it if they're hypertensive for all the potential benefits. So I am not a therapeutic nihilist at all. I feel like the data is not robust, but we haven't, if you look, and we're going to see that through the next couple of days, if you look at what we've actually studied and compare it to the acquired cardiovascular disease patients, the acquired cardiovascular disease patients had clear neurohormonal activation. They have symptoms and they had death rates. A lot of the patients we've studied aren't those patients. So I feel like I'm an optimist because I feel like we have not studied the right patients yet. And so I feel like there are a group of patients that are going to benefit from some of the therapies that you would think should be beneficial. But I will take I'm not algorithmic about it. If the mustard repair patient feels lousy on the ACE inhibitor, and I've had that happen a ton, where they get really bad headaches for some reason, I stop it. Like, I'm not willing to commit somebody to something that's making their life worse when I have no data to say that they must have that. I hopefully wouldn't do that anyway, but so I am an optimist, and I feel like we'll get ourselves to a point where we can actually get treatment algorithms that really kind of do work for the majority of patients and are based on either first principles or randomized data or registry data or all of the above.
Thanks.
Thank you very much.
Thank you.